Welcome friends, good evening, good morning and good afternoon to our viewers, chairs and speakers in Asia and rest of the world. We are back again with this week's educational lectures for you. The speaker for the first session of today is Professor Hiroki Kurita from Japan. Professor Kurita is the Vice President, Professor and Chairman, Department of Neurosurgery and Director, Stroke Center, Department of Cerebrovascular Surgery, International Medical Center, Saitama Medical University. Professor Kurita specializes in the surgical treatment of cerebral arteriovenous malformations and complex cerebral aneurysms, as well as vascular reconstruction for myomoid disease and ischemic stroke. He is a prominent faculty of the Japanese Neurosurgical Society, as well as a prominent author who has published several manuscripts in various peer-reviewed journals. We are extremely thankful to Professor Kurita for accepting our invitation to be a speaker at our webinars. Today he is going to talk about the operative nuances of hybrid repair of large and giant basilar apex aneurysms. The second speaker for today is our honored guest, also from Japan, Professor Takashi Kawahara. Professor Kawahara is the Director of Normal Pressure Hydrocephalus Center at Tsuchi Neurosurgical Hospital, Japan. Professor Kawahara specializes in the surgery of lumbar peritoneal shunt. He is also a noted author who has published several articles in this regard. He has performed more than 500 of these surgeries under local anesthesia. We are extremely thankful to Professor Kawahara for accepting our invitation to be a speaker at our webinars. Today he is going to talk about his favorite topic, surgical technique of lumbar peritoneal shunt. The chair for the first session of today is Professor Ivan Radovanovic from Canada. Professor Radovanovic is the Associate Professor, Department of Surgery, University of Toronto, and Staff Neurosurgeon at the Toronto Western Hospital and Senior Scientist, Krembil Research Institute. His research is focused on the surgical management of the ruptured and unruptured aneurysms, AVMs, and dural fistulas using minimally invasive techniques such as supraorbital and lateral supraorbital craniotomies. His research laboratory is within the Toronto Western Research Institute and focuses on the developmental signaling and genetics of cerebral AVMs and brain tumors. We are extremely honored and thankful to Professor Radovanovic for accepting our invitation to chair the first session of webinar today. The chair for the second session of today's webinar is Professor Stefan Gautenier. Professor Gautenier is the Professor of Neurosurgery at the Université de Paris and Consultant Neurosurgeon at the Hydrocephalic Clinic, Department of Neurosurgery, Hospital Bijon. Professor Gautenier has his keen interest in hydrocephalus, robotics in neurosurgery, and neuro-oncology and genomics. We are extremely honored and thankful to Professor Gautenier for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to Professor Ivan Radovanovic.
Thank you, Raja. Hello, everybody. It's a pleasure to be here with you and to chair one of the sessions of this ACNS webinar. It's very nice to meet all of you time to time on this webinars, and thank you, Raja and Professor Kato for organizing those and giving me the opportunity to join you from time to time. So without further ado, I would like to give the podium to Professor Hiroki Kurita, whom you extensively introduced, Raja. And it's a pleasure to hear his lecture on hybrid repair of large and giant basilar apex aneurysms. Professor Kurita.
Thank you very much, Professor, for introducing me. I'm very honored to have a lecture in this wonderful meeting. Today, I want to talk about the hybrid repair of complex, large, or giant basilar tip aneurysms. Firstly, I want to introduce myself to everybody. I'm now working at Saitama Medical University and served as the director of the Stroke Center and Department of Cerebrovascular Surgery. But I think almost all of you do not know where is the Saitama. So here it's a city of Japan. Here you can see the famous city of Kyoto and Tokyo. So Saitama located on the north side of Tokyo metropolitan. The distance from my university and center of Tokyo is about 50 kilometers. You well know that Kyoto is a very historical city with the history of more than 2,000 years. Here you can see some photos of Kyoto when I made a round trip with all my international fellows from Cambodia, Laos, Vietnam, and Myanmar. Conversely, Saitama is a very modern city, still developing, with many bed towns for Tokyo metropolitans. And we have famous football team, Saitama Reds, and baseball team, Saitama Lions. And our stroke center, we have the highest volume stroke center in Japan, and we have treated many aneurysms patients per year. And as a JCI authorized university hospital in Japan, we accept many foreign fellows. And these fellows actually do the cerebral vascular surgery in my department. Here, left side is a fellow from Italy, fellow from Vietnam, and fellow from Myanmar. So during the past 9 years, we have treated about 3,000 aneurysm patients. About half of the patients underwent direct clipping, and about half of the patients underwent endovascular coiling. We have the hybrid OR, brain OR in my institution, where the direct surgery and endovascular surgery and intraoperative CT is available. And all of the direct and endovascular surgery were done in this hybrid OR. So let me talk about topics. So you well know that large or giant bilateral aneurysms were unsuitable for either microsurgical clipping and intravascular coiling, and continue to generate technical challenges to our neurosurgeons. So I want to present our initial experience with hybrid surgery of clipping and coiling to discuss the role of this hybrid repair in those complex regions. Previously, we treated the parent artery occlusion and high flow bypass for these unclippable or uncoilable giant basilar apex aneurysms. But the result was not so good. This patient suffered fetal SAA 2 weeks after surgery, and some patients suffered continuous growth despite the surgery. Of course, some patients, complete occlusion of the aneurysm was achieved in some patients, but frequently associated with thrombosis of the functional P1 perforators, and functional outcomes of the patient was not so good. So we changed the surgical strategy for these complex regions several years ago to the hybrid repair. And until now, 12 patients underwent hybrid repair in our institution. All patients had complex anatomy, and large aneurysms are large in 7, giant in 5, and all patients had wide neck aneurysms, and calcified or thrombosed morphology was observed in 6. So let me show you some cases of these techniques. The surgical concept is surgical neck plasty to change the aneurysm to the sidewall type, immediately followed by coiling to reduce the perforator injury and regrowth. Patient recovered well after surgery. Let me show you the intraoperative video of this case. Using the zymatic osteotomy and transsylvian approach. Now, the basilar system is inspected. So you can see the adhered P1 ipsilateral P1 perforators. Then the endovascular streams now it's ready for endovascular parenteral gait occlusion, and microscope is reintroduced, and aneurysms was inspected again. Here you can see the tightly adhered contralateral P1 perforated to the aneurysm dome. This is ipsilateral SCA and P1. You can see here the adhered ipsilateral contralateral perforators. Now the clip is applied, preserving the perforated both sides, and ICG confirmed the good patency of the both side perforators. And angiography showed that good deformed shape of the aneurysm for coiling them, and our endovascular team completed the total occlusion of the coiling of the aneurysm by coiling. This is the final angiogram, intraoperative angiogram. So you can see here the total devascularization of the aneurysm using this hybrid repair. Then cranioplasty was done and surgery was finished. Patient recovered well without neurological deficit after surgery. This is our second case, and lively demonstrated to the link in 2013. This is a similar case. Our strategy was the same: surgical neckplasty to change the aneurysm to the sidewall type, immediately followed by the coiling for total devascularization of the aneurysm, preserving the functional perforators. This is operative video of this case. Same OZA approach, OZA Transilvan approach. Now the basilar cistern is inspected. You can see here the numerous perforator from the first portion of the PCA, and then our endovascular team were now ready for the temporal basilar occlusion. So here you can see the tightly adhered ipsilateral P1 perforators. So now the clip is applied in the same fashion, preserving the perforators on the both sides. Then ICG confirms the good patency of the perforators, and angiogram confirmed the good deformed shape of the aneurysms, followed by successful and easy coiling for complete devascularization of the aneurysms. The patient shows temporal sublunar palsy and hemidysesthesia, but modified ranking of the patient was good postoperatively. So this is our initial experience of the initial result of this hybrid repair. So complete devascularization of the aneurysm was achieved in all cases. Also, the temporal sublunar palsy was observed in 4. Permanent mobility includes quadrant hemianopsia in 2 and hemidysesthesia in 2. And modified ranking scale of the patient 3 months after surgery is good, 0 to 2 in all patients. So to conclude, our experience introduced this hybrid repair as a safe and more durable treatment option for complex basilar tip aneurysms that have a higher rate of failure with endovascular therapy and of morbidity with microsurgery. But recently, we are keeping attention to the long-term result of endovascular treatment with Pulse Rider, a new aneurysm neck reconstruction device, which introduced to our institution recently. Thank you for your attention.
Thank you very much, Professor Kurita. It was impressive series, excellent, technical surgeries and beautiful images. I have maybe I can start with one or two questions, and then we can give it to the audience. I guess what you described, for me, there are two interesting aspects. One is the hybrid proximal control of the basilar artery, where in only open surgery, you would have to do more work in the skull base and do a transcavernous approach, for example, to get to the mid-basilar and the perforator free to gain access to the proximal, whereas here, this is done in the hybrid room. So I think this is an elegant nuance. And the second is the partial clipping of the aneurysm. And there, in the cases that you present, my question is, were there cases where you could actually just complete the clipping or complete the obliteration of the aneurysm just with clipping? Because you still have to do the same work in dissecting the perforator at the back of the neck. You have to do that work to clean and to make sure that you have enough space to apply this first clip. And I understand that in most of the cases, you put some of the origin of the perforator in the fenestration of the clip to give that neck. But then, I thought in some of the cases that maybe adding a tandem clip, fenestrated clip above, could have resulted in a complete obliteration of this aneurysm without coiling. Is that the case? Or how do you select the cases, the indication, and then intraoperatively, how do you decide, okay, this now will proceed to coiling, whereas in some cases you could say maybe I can put a second clip and close the aneurysm?
Thank you for your question. Previously, I tried to complete clipping for all basilar apex aneurysms and tried to dissect the tightly adhered between the tightly adhered perforator and neck. In some patients, I succeed in the dissection the P1 perforator from the neck, but post-operatively, some patients with those successful cases showed perforator injury. So I gave up the complete clipping recently. I guess because in those cases, even if we successfully dissect the perforator from the neck, but in large or giant aneurysms, frequently the distal portion of the perforator is also tightly to the dome. So if we try the complete clipping, maybe the perforator is kinked and occludes more distal side. So we cannot control these complications. So I gave up the complete clipping for, especially in the giant basilar apex aneurysms. Instead, we currently do this type of repair. After we introduce this hybrid repair, we do not all patients in all patients we do not experience perforator injury. Do you understand what this is?
Yes, yes. Thank
Okay.
you. So is there another question from the audience?
Definitely, I would like to start with me, of course. Professor Kurita, thank you so much. That was a
Thank
very
you.
interesting lecture. But I would like to mention the problem of systemic heparinization during
Yes.
hybrid technique.
Yes.
So you have to give heparin for these patients.
Yes.
So what is the post-operative, how do you tightly regulate the INR with this technique?
Yes. Intraoperatively, we use routine heparin used for aneurysm coiling. And postoperatively, only the Zaft is used. Only the one antiplatelet drugs for 1 or 2 weeks. And we do not have the hemorrhagic complications using such antiplatelet drugs.
Our next question, Professor. Michiro Kono would like to comment, of course.
Hi, I can understand your policy, and so Kurita is one of the giants in Japan.
Not at all.
And so my question is, how do you select the approach side? Because can you always detect the perforators from the basilar top? If you can. So you can select the approach side, but I think it's not always we can see the perforators from the basilar tip. So what is your comment?
Okay, the concept of this surgery is to do not fight with perforators. So actually, it's surgical route is not the issue of this surgical technique. And with the help of the endovascular temporal occlusion of the basilar artery, I could see the contralateral P1 perforator in majority of the cases. So the approach side should be the simply the shape of the aneurysm, not the issue of the perforators.
Thank you.
Thank you. Yes, my co-host Liu Bun Seng.
Raja, thank you, Professor Kurita.
Thank you very much.
I wish to find out in your combined hybrid procedure where you apply the clip, do you see any problem, the usual with coiling, coil impaction and growth of aneurysm with the additional clip on top of it? So do you have such problem with coiling, coil impaction or aneurysm regrowth in this kind of a technique? Probably not only for basilar, but for other aneurysm too.
Yes, in my initial experience, only with 12 cases, so we do not observe any regrowth after this type of repair, because we changed the aneurysm from the terminal type to the sidewall type. But recently, the pulse rider, new device for wide neck aneurysm is introduced in my institution. So if the result of the pulse rider is good, we do not continue to do this hybrid pair. But that depends on the result of the new device of the pulse rider, I think so. Do you understand?
Yes, thank you.
In continuation to that question, I would like to mention that the philosophy of the growth of large and giant aneurysms, one of the philosophies is that the aneurysm formation and the growth is a disease of the vasa vasorum, and the aneurysms behave as a tumor and it grows on. So either with clipping or coiling, it will grow on, is one of the philosophies. That's why most of the people came back to exclusion of the aneurysm either through a bypass graft or through a flow diverter. What is your comment regarding this? So Kurita has gone offline, I think. Professor Radovanovic, would you like to comment on this?
Yeah, so I think that remains the challenge, whatever we do, and we certainly have seen cases where these giant thrombosed aneurysms with brainstem compression, where at our institution actually we have seen a few of these cases in the last years, where the aneurysm is completely occluded with endovascular means. Flow diverters, stents, and maybe coiling of the perfuse part, but leaving the large thrombosed part. And we have seen further grow, as you mentioned, as a tumor. And what we think the mechanism is that the aneurysm continues to be perfused through the wall, through the vasa vasorum, which keep this vessel wall alive and adding microthrombosis on it. And so, yes, this, I think it's an unresolved challenge it's rare, but it's an unresolved challenge in these aneurysms. So these patients who have ended up treating with steroids and following, and sometimes with bad outcomes.
Right. Thank you so much,
Yeah,
Professor
I think there is one more question from Omar Alamar.
But since our speaker has gone offline.
Hello.
Yes.
Thank you very much. Can I speak?
Yes, please do.
Before 4 months ago, there's Dr. Ibrahim Sbeh from Jordan. He tell about aneurysm, like maybe like fungal infection make aneurysm and like make some tumors, like sunlight. Can we make study about aneurysm and the fungal function, like aspergillosis? Thank you very much.
We can have the concluding remarks from Professor Ivan Radovanovic before we move on to the second speaker.
Yeah, so thank you, Professor Kurita, and thank you everybody for the contribution and the question, the very good discussion. I think it was a very interesting talk on a subject that remains very challenging for all of us, open, interventional, and hybrid surgeons. So thank you very much.
Thank you so much, Professor Ivan Radovanovic and Professor Hiroki Kurita, for that wonderful lecture. With that, we'll move on to our second speaker, and I would like to invite Professor Stephen Gotanyai to say a short introduction and invite Professor Kawahara for his.
Yes, thank you. I'm very happy to share this discussion with you today. First of all, I would like to thank the organizer to have set this webinar today. It's a pleasure for me to introduce Professor Takahashi Kawahara, who is going to give us, I think, his most precious tricks about inserting a lumboperitoneal shunt. We met a few years ago, and the discussion were very interesting. I learned a lot of things with him, so I hope that today he will show us a nice way of doing this surgery. I think that we together share the idea that shunting in INPH should be something simple and as simple as possible for the patient. We are dealing with old patients with frailty, and this local anesthesia is maybe a way to deal with those problems. So I'm very happy to chair this session, and I give you the place to speak, Professor Kawahara.
I'm very honored to have the opportunity to speak at the ACNS lecture. Thank you very much, Professor Raja, and thank you very much, Professor Kato. And today's chairman, Dr. Gutani, I'm glad to see you again.
So do I.
Thank you for your great VP shunt surgery and lecture in France. Okay.
Thank you.
Today, I'll talk about the surgical technique of VP shunt surgery. My hometown is Kagoshima City. Kagoshima City is the south of Japan. Here, This is a picture of active volcano Sakurajima Island, view from Kagoshima University Hospital. It erupts about 100 times a year, and our hospital is here. It looks so dangerous. This is a homepage of our hospital. Our hospital is the downtown of Kagoshima City. In this, Atsuji Neurosurgical Hospital was established in 1972. There are 57 general beds and 10 SCU beds. There are 9 neurosurgeons and 3 neurologists. We have 2 operation rooms, gamma knife unit, 2 MRI, and CT angiography room. In this February, our hospital was suspended for several weeks due to outbreak of coronavirus pneumonia. And these are today's main topics. First, I'll talk about INPH. The patients with INPH manifest 3 major symptoms: gait disturbance, urinary incontinence, and cognitive disturbance. The patient shows characteristic steps, especially differentiated from normal and Parkinson's disease steps. The feature of the steps are small step gait, magnetic gait, and broad-based gait. Next, I'll brief you on the radiographic findings of INPH. The excellent clinical researches were published from Japan. This paper, Symphony, reported typical INPH MRI findings. This slide shows the MRI of an INPH patient. We can recognize 4 features: ventriculomegaly, tight high convexity and medial subarachnoid space, enlarged sylvian fissure, and narrowing of the sulci with focal dilation. Japanese INPH study group called these changes as DASH. Next, I talk about the treatment for INPH, especially LP shunt. In 2015, Japanese study group published this paper, Symphony 2. It revealed that LP shunt is beneficial. Including these excellent clinical researches, there are so many reports about INPH from Japan. And these papers are referred many times. And Japanese study group published the guidelines for management of INPH. They already published the 3rd edition in 2020. This is the flowchart of diagnosis for INPH. First, we check age, symptoms, and other neurological disorders. Next, we examine a CT or MR image and determine the Evans ratio. Then we find the dash or incomplete dash. We perform lumbar tapping. We measure the pressure and check the CSF laboratory. And then we perform the tap test withdrawal of more than 30 milliliter CSF. When a good response of cognitive function and motor function are obtained by careful evaluation, the current surgical approaches for INPH patients are shunt operation. There are three types of shunt surgery: VP, VA, and LP shunt. And after Symphony 2 study, 55% of INPH patients are treated with LP shunt surgery in Japan. I think that there is another reason that so many patients are treated with LP shunt in Japan. I think that the Japanese body shape is suitable for LP shunts, and many Asian peoples are also fit for this surgery. The average of Japanese body mass index is 23. Japanese people have less subcutaneous fat tissue and visceral fat. So when we perform the lumbar tap, spinous processes might be easily confirmed, and the insertion of the abdominal catheter into the abdominal cavity is also easy. My BMI is 26, so I exercise very much to get a body shape suitable for LP shunt. In fact, Japanese Dr. Kuana inspired this method by the failure of the epidural anesthesia. This is a surgical manual of LP shunt published in 2006, which is edited by Dr. Kuana. In this manual, general anesthesia is recommended for LP shunt surgery. However, under such circumstances, Dr. Atsushi started the LP shunt surgery with local anesthesia in our hospital from 2007. As clinical research Symphony 2 revealed that LP shunt is similarly effective to VP shunt, and it is less injurious, and it can be performed under local anesthesia. So it is less possibility of severe complication during and after LP shunt surgery under local anesthesia and modified NLA. In our hospital, the number of LP shunt surgeries gradually increased, and 95 cases were operated last year. . Next, I'll show you the video and talk about the result of this treatment. Patient is lateral position. This is abdominal side, back side, patient head, patient foot. No positional alternation during the surgery. 2 operators are required in front of and back of the patient. This is a perforated sheet for LP shunt surgery. It is useful for shortening of the surgery. In this case, there were 3 operators. She was the resident neurosurgeon. And we inject lidocaine back and flank and abdomen area. She already started operation. Unfortunately, she could not succeed the lumbar puncture. This is view from the back side of the patient. Dr. Atzi performed diagnostic lumbar puncture with medial approach. He is a master of backside procedure. We check the direction to the spinal canal and check the depth of the to the spinal canal and puncture by toy needle with paramedian approach. During the spinal catheter insertion, we ask patient whether the radicular pain occur or not. A skin incision is performed before pulling out the toy needle for avoiding damage of spinal catheter. Minimum subcutaneous space is created for valve pressing. Local anesthesia injection is not required for this procedure. We pass the catheter towards the flank with inline passer. Place the programmable valve in the subcutaneous space. cut the spinal catheter and connect the spinal catheter to the valve carefully. And ligate firmly with nylon thread. And this is the view from abdominal side. Abdominal procedure is started as soon as the confirmation of the spinal catheter insertion. We use blunt scalp hook for pulling up abdominal rectal muscle and peritoneal membrane. Like this video, the surgical field is closed to surgeon by using these hooks. It is easy to spread the rectal muscle without using muscle reductant. We pass the distal catheter from the flank to the abdomen with inline passer and pull out the catheter between the fat layer and anterior fascia. The abdominal catheter is passed obliquely through the anterior fascia and the rectal muscle with mosquito forceps, and then pressed into the space over the posterior fascia. Since it is surgery under local anesthesia, the peritoneal membrane incision should be made as small as possible. Now, cut the membrane. And the catheter is inserted into the peritoneal cavity. After this procedure, abdominal catheter is covered by abdominal rectal muscle. The catheter would not be placed in the subcutaneous free space, which was made by surgery. The visible length of catheter is very short. Here. Close the fat layer tightly. We always finish the surgery for about 30 minutes. Next, in this way, LP shunt can be performed simply and safely. And the Symphony 2 study reported that clinical results were good 1 year after the LP shunt surgery. But how about the long-term result? I'm following all 37 post-operative cases operated in 2017. The average age at the time of surgery was 77. All cases have been followed up. I'm sorry for this rough evaluation. 51% of cases are in good condition. 10% of cases worsen comorbidities such as AD. 21% of patients are hospitalized or admitted to nursing home due to subsequent illness or trauma. 16% of cases are dead. In other words, half of the cases remain in good condition for 3 years. Next, I'll talk about the complication of LP shunt and proper prevention. We reported the complications of our cases a few years ago. This table is intraoperative complications. We could not finish the LP shunt surgery of 9 patients under local anesthesia, but no serious complications were observed during the surgery. This table is post-operative complications of LP shunt surgery. Posterior headache is the most frequently observed complication. Migration of abdominal catheter is decreased for recent 5 years, and no serious complications were observed after local anesthesia operation. The frequency of the complication is similar to the data reported in Symphony 2. First, I'll talk about the subcutaneous migration of the abdominal catheter from the peritoneal cavity. Radiographic examination disclosed the presence of catheter in the abdominal wall. This incidence is 5 to 10%. This is an abdominal CT image. Abdominal catheter is existed in subcutaneous space. Subcutaneous migration of distal catheter is also found after VP shunt surgery. We invented the simple method to prevent this migration. The abdominal catheter is pulled into the space between the subcutaneous fat tissue and the anterior rectal sheath at the upper corner of the wound. The abdominal catheter is passed obliquely through the anterior sheath and rectal muscle, and then placed in the space over the posterior sheath of the rectal muscle. Insert the catheter into the peritoneal cavity and close the anterior sheath. Then almost all the catheter might not be observed in the subcutaneous space. It is very simple. We call this technique penetrating abdominal rectal muscle method. Dr. Sameshima added the Z suture. This is a Z suture for completely disappearing abdominal catheter in the subcutaneous space. Basic concept of our technique are minimizing the dead space around the catheter, minimizing the subcutaneous fat tissue effect, and minimizing the effect of intraperitoneal pressure to the catheter. In this way, the migration rate was significantly decreased. Next, I'll talk about the lumbar shunt tube rupture. In our hospital, half of them were occurred around the connector. There are three patterns of tube disconnection from the connector. Simple detachment, rupture on the connector, rupture at the end of the connector. We experimented on the relationship between connection method and tube rupture. Group A is using finger wearing surgical gloves. Group B and C connected with scissors, gripping the catheter on the part of the connector. Group D and D connect with scissors, gripping the catheter only. Group C and E use scissors covered the tip by silicone tube. We performed each procedure 5 times and compare the number of cracks. No cracks occurred in the finger-connected group A, and group D and E that connected the catheter with scissors without touching the connector did not crack. On the other hand, when we touch the connector part with scissors, even if the tip of them were covered by silicone tube, it is easily damaged. Next, I want to talk about other major complication of LP shunting, overdrainage. As already reported, overdrainage is important complication after LP shunt surgery. Similar to spontaneous intracranial hypotension, postural headache, subdural effusion, and subdural hematoma might be appeared under this condition. This flow chart is our strategy against overdrainage. We use the Codman Certas Plus valve, which can set the maximum pressure to over 40 centimeter H2O. The initial setting is the maximum pressure of 40 centimeter. And 1 week after surgery, when the patient had no overdrainage symptoms, we decrease the valve setting. And then the overdrainage happens even at the highest valve pressure setting. The patient would be treated with an additional tandem valve method. This is an abdominal röntgen before adding tandem valve method. The valve was already set to the maximum pressure. The patient remained bed rest, but overdrainage did not improve. In this case, an additional valve is connected in tandem at the flank. As Dr. Nakajima reported, the gravity valve was connected vertically to the catheter. This is a post-operative röntgen. This additional tandem valve method has resolved the overdrainage in all cases in our hospital. Although it seems possible to treat post-operative overdrainage with the tandem valve method, there is no appropriate guideline how long the patient should be bed rest in the condition of overdrainage. On this subject, a clinical study conducted by Kagoshima University and Atsuji Neurosurgical Hospital is being submitted to a medical journal. I would like to talk about it at the next opportunity. These are important points of INPH patient follow-up. Several important information can be obtained from abdominal röntgen. Neurosurgeon might be quickly aware of the complications. Reserving the next outpatient visit is the key to continuing follow-up. When the LP shunt is not suitable for the INPH patient, we consider VP shunt or VA shunt. This is the last slide. LP shunt is minimum invasive procedure for INPH treatment. Penetrating abdominal rectal mass method with Z suture is simple technique for preventing abdominal catheter migration. Post-operative upward drainage is the most serious complication, and it might be solved by tandem valve method. VP shunt and VA shunt are also necessary for INPH treatment. Thank you very much.
Thank you very much for this talk. You can believe me, after talking with you 2 years ago, I tried to do LP shunt under local anesthesia, and it is really true that you can tunnel through the abdomen without any pain. So if you want to try it, I talk for the other people in the audience, it is possible. I was surprised about that the first time you told it to me. Are there any questions?
Start with Professor Liu Bun Singh. Yes.
Hello, Prof. Hello, Prof. Thanks for a very nice presentation. My question, Prof, in case that if I fail to tap the subarachnoid space for the CSF, is there any other option? Is there any open method that can be deployed to get the CSF function?
I think the question is, if you cannot perform the LP shunt, what can you do? Do you do an open procedure exposing the lamina, or do you use X-rays, or do you always succeed in performing the LP shunt, the LP tap?
We do LP shunt about 90 per year. Only one patient couldn't be treated LP shunt because of lumbar puncture failure. The reason why is LCS or lumbar herniation. So we decide another type of shunting. Always VP shunt or VA shunt. Last year, 6 patients changed the shunt operation from LP shunt to VA shunt.
One more question, Prof. Most of the patients with idiopathic normal pressure hydrocephalus, they are elderly. So they usually have a lot of spinal degenerative changes, osteophyte formation, all the things. Do you have any specific protocol in terms of X-ray of the spine, either in flexion or flexion position, to see whether to judge how much chance that you're able to perform the LP shunt? Do you have such protocol to look at the imaging, spine imaging, X-ray?
We examine röntgen, lumbar röntgen, and 3D CT and MRI, lumbar MRI. We consider we can do lumbar puncture or not. So deformity is severe patient. We do VP Shunt or VA Shunt, firstly.
Thank you. Dr. Kawahara, thank you for the good lecture. I'm Dr. Kon from Tokyo Showa University. I sometimes use LP shunt for the patients, and our residents are struggling and sometimes asking me for help. But for obese patients, it is very hard to open the abdominal side because too many lipids covered with lipid to open this lateral posture. Very difficult to open the abdominal side. Do you have any tips for such patients to have tips? Because our residents struggled for such patients. And even if I help them, I also struggled. So do you have any tips for obese patients to open the abdominal side and keep the lipids?
We use blunt scalp hook and rubber ring.
Rubber ring. So larger one.
Larger one.
Bigger one. Okay.
Bigger one. When we use blunt scalp hook, the depth of surgical field up about 3 centimeters. It is very easy. And when we operate fat patient, we create skin incision for longer.
Okay.
And long skin incision create subcutaneous abdominal catheter migration, but my technique, penetrating rectal muscle method, prevent migration of abdominal catheter. So making large skin incision is not matter.
Okay, so the longitudinal or transverse?
Yeah.
Transverse, okay, thank you.
Right, thank you. Yes, my friend Bobby.
Yeah. Thank you, Dr. Raja. Thank you. Excellent, Professor. Thank you for that very excellent deliberation on that local procedure which can be done. But may I just humbly ask you, I mean, what exactly do we gain by doing the procedure under local anesthesia? Why don't we do it under a general anesthesia? Because the patient's discomfort definitely will be, at some point, there will be some discomfort for these patients. So all patients need not be very cooperative with our local anesthesia in spite of the neuro-left analgesia which we are giving. So why don't we try exactly it under the general anesthesia itself? What is the real purpose of changing over this procedure to a local anesthesia procedure?
I'm sorry, I haven't.
Maybe I can help you for the answer. I guess the question was, why are you performing this surgery under local anesthesia instead of general anesthesia?
Exactly.
Because it seems more comfortable both for surgeon and patient.
We asked the patient after surgery, when you have an opportunity, another shunt, do the patient request same anesthesia or not? Patient always answer they select same anesthesia.
Okay.
I guess that is the patient's choice, of course. I think.
Yeah, exactly.
General anesthesia, patient image is general anesthesia is dangerous.
Okay. Okay.
Local anesthesia is safe. Patient image, patient have such image. So we talk about
Okay. Thank you. Thank you.
yeah, they do shunt operation.
Okay, sir. Okay. Thank you. Thank you.
Thank you.
Right. Thank you so much. I guess Professor has answered that question well. Yes, Dr. Omar would like to comment. Yes, yes.
Thank you very much for the good presentation, Professor. I asked for the valve pressure. How much it's open? What's pressure uses for the valve tandem?
Initial valve setting is highest valve setting. We use Codman Sartas plus valve. So we use initial valve setting as a virtual over
the pressure is 400 millimeter.
Yeah. That's right.
Right.
Very
Thank
high.
you so much. Very high pressure.
I think INPH is gradually worsen disease. So we improve not rapidly. So we decrease gradually valve setting.
Right.
And
Thank
the
you so much.
first decrease in valve setting, when does it occur? After 1 week?
Yeah.
Is that true?
That's right.
And how much do you decrease and how fast and how far is your goal?
Initial setting is for 40 centimeter, and 1 week after 20 centimeter, and next month we change the 17 centimeter.
There have been a few questions here in the chat box. I would like to ask that, do you believe in advocating drainage LP for improving symptoms for 3 days?
The question is about using only lumbar tap test once or twice, or using an extensive lumbar drainage for a few days to look for.
Sorry. Thank you very much. I understand. We check the lumbar tap test only one time.
I think it's time for conclusion. We would like to hear the concluding remarks from Professor Ghataniai.
Okay, I think that this discussion was very interesting. I was very happy to have this exchange with you today again.
Thank you very much, Dr. Ghataniai.
Thank you for the organizer, and I hope we'll meet very soon.
Thank you so much. We have our first chair and first speaker back online, Professor Kurita.
Thank you very much. I'm very sorry. During this meeting, I have some trouble in the communication on the PC. I'm very sorry, but I enjoyed really this morning, this meeting. Thank you very much to everyone. Thank you very much.
Thank you. Yes, Professor Ivan Radovanovic.
No, thank you very much, everybody. The speakers, very interesting talks, and the session overall, good discussion. Thanks to everybody.
Thank you so much, everybody who joined in. With that, I'll close this officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to sincerely thank both the speakers for today, Professor Hiroki Kurita and Professor Takashi Kawahara, as well as both the chairs, Professor Ivan Radovanovic and Professor Stephen Ghataniai, who came here and gave their time in support for the ACNS webinars. Thank you, everybody who joined. Thank you, dear Liu Bunseng, my co-host for today. And with that, we'll wind up this session. See you all on next Saturday.